Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much for joining tonight this very interesting program of the point of care ultrasonography in acute care settings, the ED section, the advanced module. And this is a live webinar for the fellows in the ED section in the emergency department point of care ultrasonography advanced module section. We make this open for the public, for everyone interested in point of care ultrasound to join us and to have an idea about what we are doing with our faculties. The main objective and the main idea behind this program, which are the online fellowship programs that we started from mid-2025, is to deliver the knowledge and actually to enhance the environment of using this very valuable tool at bedside in acute care settings. Acute care settings could be emergency department, could be intensive care unit, could be OR, it could be the recovery room, it could be anywhere where the critically ill patients or acutely ill patients are there. And we are very keen with the WICCAM, Suno School, Saving Lives Academy, to, as I said, deliver as much as we can the experiences, the knowledge, the science, how to do this science bedside. This is our aim. And the reaching a wide target of all physicians working at bedside with acutely ill patients is our aim actually. And that's why we're gathering tonight four more, plus me, four of the eminent speakers in the emergency medicine: Dr. Haitham Khalifa, Dr. Wissam Ibrahim, Dr. Magid Al Warraqi, and Dr. Muhammad Abbasi. They are all working and they are consultant in acute medicine, in emergency medicine, with a lot of experience in point of care ultrasound utilization in this environment. Tonight, we decided to make it an interesting case discussion, case presentations, and discussions, of course. We bring you cases from our library, and please feel free to communicate with us, asking your questions. And of course, one of the main idea for the live webinar every 4 weeks of platform materials, we meet live. And the main purpose of this meeting live is for the fellows to raise their questions, their concerns, their misunderstanding or full understanding of the material endorsed to them through the platform on the previous 4 weeks. So please, our fellows in the ED advanced module, put your questions in the Q&A section of the Zoom, and Dr. Haitham Khalifa will handle the questions to all of us if needed. We're going to start this webinar now with the first case. Hopefully, Dr. Muhammad Abbasi is ready to present his case.
Yes, I sent a request to share my screen.
Yeah, Dr. Muhammad Abbasi is a consultant and assistant professor of emergency medicine in Canada. Can you introduce yourself, Dr. Abbasi?
Assalamu alaikum. Welcome, everyone. For people who don't know me, I'm Muhammad Abbasi. I'm currently emergency medicine assistant professor at Northern Ontario School of Medicine in Canada. I finished my Egyptian board in 2009, Gamal Abdel Nasser, Alexandria, Egypt. Then moved to Saudi Arabia, from Saudi Arabia to Qatar, where I got the Royal College of Emergency Medicine. Then I had the European Board of Emergency Medicine before moving to Canada and getting my Pocus fellowship at McMaster University in Canada. Then I'm working now as assistant professor of emergency medicine and point of care ultrasound lead at Soo Area Hospital in Northern Ontario. I wonder if you can see my screen.
Let me stop sharing first, and then you share your screen kindly. Otherwise, if Nurhan is ready to share your presentation, it's already shared in WhatsApp. Yeah, I think we start.
I will share my screen.
Nurhan, stop sharing.
Nurhan, let me share my screen.
Great.
So do you see it full screen now?
Yeah.
Okay, that's good. So starting with our first case for tonight, it's the way I can see it, I want to make it a real-life patient interactive presentation. So I have a 61 years old male patient presented to the emergency department with shorter breath. Initial ECG is normal and chest X-ray was normal. Lab investigation showed that his pH is 7.2, lactate 4, and troponin 1800. Our maximum level here may be 20, so that's really high. So you got in your mind some differential diagnosis. Is it cardiac related? Is it pulmonary related? So you decided to move to point of care ultrasound to help you to answer some of those questions. So we start by introducing this first clip. So this is apical four-chamber view. As you can see, right ventricle, LV, and that's the free LV wall. And as you can see, or can you see my cursor, Dr. Ashraf?
Yes.
Okay. So as you can see here, the RV, there's massive RV dilatation. The RV is almost equal size or more or bigger than the LV, and some septal flattening. And if you focus on this area of the RV apex, you can see the free RV wall is completely akinetic or hypokinetic, but there is a hypercontractile RV, which you can see it, or you can indicate its McConnell sign. Let's move to the short axis view. That's one of the typical photos or images you can see in massive RV dilatation or massive RV increased pressure, when you can see the RV is bigger than the LV, and you can see septal flattening and D sign. So when you put your probe and for apical chamber, for chamber or short axis or long axis, and you decide that this patient is having massive RV dilatation, I can see massive increase in RV pressure. I'm suspecting the patient might have pulmonary embolus. So I want to move to like some other test using point of care ultrasound. So our next step to see, sometimes it might be advanced, although I can see a bit easy, it's the TAPSE. If you've gone through the previous module, the transannular plane systolic excursion, where you can detect the distance between the movement of the tricuspid annular, our annulus, up and down, and detect that space here. Our cutoff limit is 16. So any number below 16, that's indicative of increased RV pressure. You decide to move next to confirm through IVC, and you went to the subxiphoid area. You put the probe in the subxiphoid, aiming the probe marker to the patient head. You get this view where you can see the IVC aiming to check the size. If we check that size here, most probably it will be more than 2.1, 2.2, or above 2. And the respiratory variation, definitely there is no respiratory variation here. You are aiming for normal people to see more than 50% of respiratory variation. Here you can see hardly any respiratory variation. This is indicative of increased RV pressure. You decide to do another confirmatory test and went to examine this patient leg. And either you use 2-point protocol, 3-point protocol, or you scan the whole deep venous system in the leg. We'll go through that in the DVT lecture. But if you go through 2-point or 3-point, and at the level of the popliteal artery, you see all these veins compressible, but here you can see clot in the popliteal vein. So that's almost, you are 100% sure now that the reason of hemodynamic instability of this patient is mostly due to massive pulmonary embolus. You can see clot distally, you can see hemodynamic instability, and signs of increased RV pressure. So you decide to send this patient to CT scan. So the CT scan showed large saddle embolism with large thrombus load, occlusive thrombus extending into the left lower lobe bronchial artery, and near occlusive thrombus extend to the right lower middle and upper lobe pulmonary arteries. And the CT suggestive that the patient is having RV strain, with the interventricular septum is mildly bowed towards the left ventricle. For the CT finding, similar to the Pocus finding, you might find the septal bowing. The contrast might reflect to the IVC, indicating increased RV strain, and they use also some measurement to detect the LV diameter or RV to LV ratio. It's done by different calculations, different methods, but the radiologist can detect this patient is having signs of RV based on the CTPA. But do you think that the RV strain or increased pressure in the RV is quite sensitive in CT scan? CT scan can detect it. I want to present two quick um, articles. The first one published at the American Journal of Emergency Medicine. It was basically wants to diagnose the centrally located pulmonary embolus that might have impact on hemodynamics, and it's done on 208 patients enrolled to diagnose Pocus finding based on the RV strain, based on the RV dilatation or a McConnell sign or TAPSE. And they found that when you use the point of care ultrasound bedside echo along with the DVT, they found the sensitivity almost 100%, and the specificity was 98. They concluded that the emergency physician performing point of care ultrasound may be sufficient to exclude the presence of centrally located or massive PE that can affect the hemodynamics with sensitivity 100%. It's similar to the CTPA. So if you don't have in a low resource setting, if you don't have an available CT, or if you don't have accessible CT, machine is down, you can trust your judgment based on the bedside point of care ultrasound and add to that a DVT study. Another study published at the Academic Emergency Med for the emergency physician doing RV strain and acute pulmonary embolus. They found that in acute PE, CT is highly sensitive, but it's not specific to the acute RV strain compared to transthoracic echo. If you combine the transthoracic echo and the CT, the results would be good, but only CT scan. If you use it, it's not that specific for acute RV. So we have what to conclude. The CT versus point of care. Signs of RV strain are similar on CTPA and point of care ultrasound. The CT pulmonary angio is sensitive, but not very specific for RV strain. And the Pocus is sensitive and specific in diagnosing RV strain compared to CTPA. To quickly summarize, for what's the echo finding or Pocus finding to suggest RV dysfunction in PE? First of all, the RV dilatation, atrial dilatation, septal bowing, McConnell sign. You might be able to see tricuspid regurg. You can see RV thrombus dilated IVC, and if you measure the TAPSE less than 16. As you see here, the RV dilatation is our first marker. You are aiming to see RV to LV ratio. In some studies, it's 1 or 0.9. You're focusing on the increase RV relatively to the LV. It's not 2/3, 1/3. It's almost half and half. And the affecting hemodynamics when the pressure increased in the RV, putting some pressure on the free alveole or the interventricular septum, you will find the D sign. Then IV assessment, you are going to check the diameter, aiming for 21 millimeter or above 2 centimeter, and you are aiming to see for normal patient more than 50% respiratory collapse. The other piece, if you can see the clot, you can see it in less than 4% of patients. Increased a bit higher in the ICU patients, but if you can see it, that would be perfect. And the McConnell sign, it's highly specific for PE, but it's not that sensitive. So don't use it alone. Use it in the context. And the other two pieces, or three pieces, I find that it's a bit maybe advanced, but we can discuss in details on the WhatsApp. The TAPSI, if you can measure it, and now there is a higher importance for the 60-60 sign. You are aiming to check the pulmonary acceleration time less than 60, or tricuspid regurg peak gradient less than 60. And if you combine it together, that's really higher indication for acute increased pulmonary pressure. And the final one, I didn't do it myself, but it's highly emphasized now in the literature. It's the early systolic notching. Maybe we can highlight it later. And I want to bring that from 2026 American Heart Association guidelines recently published. They categorize Pocus finding in RV dysfunction as category C, highlighting the RV to LV ratio, the septal flattening, the TAPSI, and the 60-60 sign, and the end systolic notching. I know I took more than the time I supposed to do, but if you have any questions,
Thank you.
Dr. Haytham.
Thank you, Dr. Mohammed, for this nice presentation. One candidate is asking in the emergency department, if the patient is unstable, depending on his history, there is high probability of BE plus suggestive echo finding. Would you thrombolize without seeing a clot? No clots in leg scan.
So it depends if you have a CAT scan or no available, and how quickly you can get the CAT scan. Here in Canada, we thrombolize patients hemodynamically unstable in peri-arrest condition, or just we diagnose in the patient arrest based on the bedside point of care ultrasound only findings. If the patient is hemodynamically unstable and high probability PE, and I found maybe a clot in his leg or massive RV, and I don't see a thrombus, yes, I would thrombolize. If the patient, you are continuing resuscitation for this patient and sending for a CAT scan, and it won't affect the patient condition or delay the diagnosis or treatment, or you are waiting for the drug to be available, you can do it. But yes, of course, if you are suspecting based on the Pocus finding and hemodynamic instability, high probability score, go and thrombolize.
Any other question for Dr. Mohammed? If any other question, please write in question and answer. Okay, I think no more questions for this case, Dr. Mohammed. So now the mic with you.
So our next presenter is Dr. Wissam Ibrahim. He is an assistant professor of emergency medicine at Colorado University, and also a faculty at Tanta University. Mic is yours, Wissam.
Thank you so much, Dr. Muhammad Abbasi, for introduction, and thank you for make everything easy for me and this next lecture. Actually, my lecture is that one of Dr. Muhammad Abbasi lecture. It is the chronic case, what's called core pulmonal as the chronic pulmonary hypertension decompensation. Our case started by 65 years old male with long-standing COPD, progressive shortening of breath, fatigue, mild confusion. The vital blood pressure is 95/60, heart rate is 110, and respiratory rate is 27 cycle with saturation 84% in room air. Bilateral lung examination shows decreased breathdown with the background of this COPD and wheeze. bilateral lower limb edema, hepatomegaly, elevated jugular venous pressure, and on the heart, there is like a loud P2 sound indicated maybe pulmonary hypertension. What is the Pocus rule in this case? It is the same exactly as Dr. Muhammad did. What's our probe used? We will use linear probe, curvilinear probe, phased array probe, unless you don't have one probe. So the Joker probe is the phased array probe. Now we will go the 4-chamber view in echo. We will put the phased array probe here at the apical pulse of the patient. For better view, we make him living on his left side with the arm above the head. The indicator here, if you are cardiac based, it will be to the left of elbow in the neutral position. What's meaning of left elbow in neutral position? Here, as you already elevated your hand. So it will be here by my laser mark. Now, we will do the apical 4-chamber looking for the RV, right ventricle. Remember that in normal physiology, left ventricle is 2/3 of right ventricle. But now we don't even looking for equality. We are looking for an equal, like right ventricle is more size in order not to make any debate. So the right ventricle here is larger than left. Here it's right ventricle larger than left. And with long standing, we even found that the right atrium is larger than the left atrium. So our first view is parasternal, is apical 4 as previous show. Now parasternal short view. Where to put your probe? Your probe here between second and third intercostal space. Usually, as a technical, you start looking to the right shoulder to get the parasternal long view first, even if you need the parasternal short. But as a technical, you start by getting the parasternal long, looking to the right shoulder, then rotate 90 degree to find on the left from 90 to 180 degree to reach the left shoulder. So the indicator looking to the left shoulder, the space is on the left side between second and third intercostal space, or third and fourth intercostal space, where lying the bare area. If you remember, you have many levels. If you're looking down, it is the apex, then the papillary muscle, then mitral valve, then aortic valve, then the very upper is the pulmonary artery level. Here the parasternal short view. At the mitral valve, it's called fish mouth. It is a normal landmark. Fish mouth. You will look for this fish mouth. Normally, it is round or oval. Round or oval, as I show by my screen. Round or oval. So what happened if the pressure increased on the right side? It become a D shape. D shape. Look at D-shaped sign. So this deep shaped sign starting by enlarging the right side, first straightening the interceptum, then pushing the interceptum to form this D shape. What's like more advanced, what is called jet, tricuspid jet or tricuspid regurg jet. Usually, there is like a trivial regurg in tricuspid, which is accepted and normal. But what is it like? Increase the pressure, so now there is a regurg. Regurg meaning blood coming from the ventricle to atrium. Usually in systole, the blood not return. It coming from the ventricle to pulmonaries or ventricle to aorta. On the right side, it is ventricle to pulmonary, not ventricle to atrium. So at the systole, we put the color Doppler. You will find this mosaic shape. This mosaic shape indicated blood coming from ventricle to atrium. Remember, you are still in apical 4 chamber. Now we will do continuous wave at Doppler. Doppler is measuring of velocity. We put a Doppler here to measure the velocity of this tricuspid regurg. So starting, find the tricuspid regurg or no. You didn't find tricuspid? Okay, doesn't go to the next step. Stop at this step. You find the regurg. Excellent. You put color Doppler. You found the stream. Put your precursor as a continuous wave Doppler. It will draw this wave. It will draw this wave. Normally, it is below 2.7. Remember 2.7. I try to unified number. 2.7 meter per second. So this is normal. Look for this picture. You will find the jet is 4 meter. It is high jet. It is high jet. With Doppler, you measure velocity. With Doppler, you measure velocity. What about transform this velocity into a pressure gradient inside the ventricle? Transform this velocity into pressure gradient. Should we do anything else? No. Just with the same calculation, press on the device. The device is built on calculation called a Bernoulli equation. Forget for the name. Bernoulli equation, it is just the equation of 4 multiplying of the square of the velocity. Forget the equation. Just remember that the number is always below 35. So, as a consequence, you did the regurg. No regurg, didn't do anything. There is a regurg. Do the tricuspid jet. You found the jet. Put your continuous wave Doppler and find the gradient. The gradient is normal, so the pulmonary artery pressure is normal. If the gradient is not normal, you can do another thing here. It is, you will find the parasternal short. You remember the parasternal short level start by apex, papillary muscle, mitral, aortic, and pulmonary artery. You will find this few. Put your precursor here at my laser site, just behind the pulmonary vein or just above the root ventricular output tract or outflow tract. This time it is a continuous, not continuous wave Doppler. It is a pulse wave Doppler. What you will see this triangle. You will measure what's called accelerating time. What is the accelerating time? It is the pushing inside the pulmonary, like it start to the peak, from the start to peak. How long does it take? From this all number, we can reach a very beautiful thing to reply to Dr. Muhammad Al-Abbasi. He said that we use the same parameter in pulmonary embolism as I used my same parameter in core pulmonale. So what is the difference? The difference that tricuspid regurg gradient in pulmonary embolism never above 60. If it is above 60, it is a core pulmonale. The right ventricular outflow tract accelerating time, in my case, it is more than 100, less than 120 and more than 60. If it is less than 60, it is a pulmonary embolism. And those two signs is the more specific sign to differentiate between pulmonary embolism and core pulmonale. What about McCullen sign? What's McCullen sign? McCullen sign sometimes it's defined as hyperactive apex, but this is like a deceptive or not accurate diagnosis because it's not hyperactive apex. It is a normal apex, but the lateral wall is lazy. The lateral wall is dyskinetic. The lateral wall is akinetic. So by the reverse, you saw the apex as more working. Is this sign, is it specific for pulmonary embolism? No, it can be found in right ventricular infarction or right ventricular ischemia. That's why we use this two sign known as 60 per 60. Less than 60-second accelerating time, less than 60 millimeter mercury as a gradient. Above that, core pulmonal, below that, pulmonary embolism. The last thing relating to post-core pulmonal and the pulmonary embolism, something used by MO. First, we start by 2D, which apical view and short axis view. Second, we use Doppler, continuous wave, Doppler for the gradient, or pulse wave Doppler for accelerating time. The third thing, we use the M mode for the movement of what is called tricuspid annular plane systolic extrusion or excursion. So it is in systole and it is measuring the movement of this lateral side. If this movement is more than 1.7 centimeter, it is normal. Below than 1.7 centimeter, it is abnormal. And in order not to confuse, we have two main numbers. For TAPSI, 1.7. For tricuspid jet, 2.7. You remember that. The last thing we go with the echo, we will go with the IVC, and we will go with the lung. With the IVC here, remember that your probe is longitudinal. It is subcostal, but in this time, it is longitudinal. It is not transverse. In subcostal view of the echo, it is transverse. In IVC, it is longitudinal. You will find the IVC, and behind the IVC is the aorta, and behind the aorta is the spine sign, or the spine. IVC have hepatic vein, and here is the right atrium. We measure here, just behind the hepatic vein, or 2 centimeters, it is the same. 2 centimeters from right atrium or just behind hepatic vein. You can do it as a 2D eyeball, or you can use the M mode using either this collapsibility in normal ventilation or distensibility in ventilator patient. Now go to the lung view. You will go to the anterior of the lung and you will find A line without P line, so that it's totally dry lung. Here the dry lung with A line. Remember that P line more than 2 line is pathology and it's edema. Here in our case, it is totally A line, which present in air and COPD. The other differential diagnosis is pleural effusion. It is out of the scope. Effusion is fluid, not inside the lung. Pleural outside the lung. Now, as a Pocus person, you put all your videos and decide. Normal lung with no P line. D shape. Right ventricular enlargement. Plethoric IVC, it is a case of core pulmonal. Pathophysiology, hypoxic doing vasoconstriction, doing pulmonary hypertension, increase the right ventricular overload, lead to dilatation and failure. So it is a problem of overload, not fluid. Remember, oxygenate the patient, never give much fluid, pressure if the blood pressure is low, and treating the underlying cause. Core pulmonal, again, it is a pressure problem, not a volume problem. Thank you so much, and waiting for your questions.
If any question for Dr. Wissam, thanks, Dr. Wissam, for this great lecture. If anyone has any question, please write in question and answer, and we'll ask the question for Dr. Wissam. I can see that there is no question. So, Dr. Wissam, can you please introduce Dr. Ashraf?
Okay, it's my pleasure to introduce Dr. Ashraf Al-Tayyar, our program director and the consultant of acute medicine at King Jamal Hospital in United Kingdom, EDIC and the American Board of Critical Care ECHO certified, Pocus Fellowship Program Director and the EDIC Supervisor and Master Class Course Director. The floor is you, Dr. Ashraf.
Thank you very much, Dr. Wissam. You see my slides and you hear my voice very well?
Yes.
Yeah, so I hope Habiba or Nurhan is ready with the poll. Once I go to the question, please put the poll if possible. I present a case here, which you can see in emergency room as well as we see in ITU or ICU. So 53-year-old female who was recently diagnosed to have a disseminated malignancy with lung, liver, lymph node, and bone metastases. The primary source was colon and lung. The lady presented to, let's say, ED. She presented when she was in ICU, in severe acute respiratory failure. She was hypoxic, gasping before intubation, then required to be mechanically ventilated, stable initially. The echo was done. Can I ask you the first question here in the poll, if Habiba can put this? And the question is, do you do Pocus routinely in your ED and ICU? If you have hemodynamically unstable patient and or respiratory failure, do you think of Pocus as you think of other tools, or you don't give it priority at all? Please vote in here. Do you use it? Yes, no, or hope, but it's time consuming and I cannot do that. Please, everyone share, because we need to know. Can we see the responses, Habiba? Stop, Habiba, and show us the responses if possible. Yeah, so here, 75% of the attendees tonight do a point-of-care ultrasound exam for their patient as routine. And actually, this has to be the routine practices, because any patient who presents with cardiovascular failure or respiratory failure should have reason refer to heart or lung or both. And as we used to say several times, that the most common reason for the respiratory system to fail is cardiovascular system failure and vice versa. And actually, we see a lot of people, they jump and do chest x-ray and they may request CT, while they can have, as Dr. Abbasi showed us and Wissam showed, and very nice cases of how the point-of-care ultrasound at bedside can answer the question in mind. And actually, the point-of-care ultrasonography golden rule for is that it should be a focused, goal-directed exam to answer certain question in mind. Do I have this or I don't have? The answer are usually has to be yes, I have, no, I don't, or I don't know. So one of the first things that I believe has to be done is to look at the heart, see how the heart of this patient is behaving, because this will open at least the differential diagnosis for you. So we do routine examination of our patients who present with respiratory or cardiovascular insufficiencies to ED and ITU. And what you see here, this is the apical 4, this is the parasternal long, this is the parasternal short. Walls are anterolateral, and usually, not usually, but all the cases, when you see the lateral, opposite to the lateral, you see the septum, and then What you see here in the parasternal long is the septum and the posterior or inferior wall. And then in the short axis, which is one of the best views to comment on different walls of the heart, is to see here anterior wall. Here is the septum, opposite to the septum, lateral. So this is the lateral. And opposite to anterior, here is anterior, opposite to it is inferior. Inferior wall, anterior wall, septal wall, lateral wall. You could call this as anteroseptal, infroseptal, and infralateral, anterolateral. So on this, we don't see any regional motion abnormality, and actually the patient was hemodynamically stable. As I mentioned before, she presented with respiratory failure, but looks like the systolic function is maintained. But please look at this apical 4 and put in mind to comment or to keep it in your mind, how is the RV, because we're going to need this later on. The systolic function of the left ventricle can be assessed, as we heard from Dr. Wissam and Dr. Abbasi. We use the TAP-C on the right side. We can use MAP-C on the left side, but we can also use the tissue Doppler. We fire the tissue Doppler in the mitral annulus, medial one and lateral one, and you can have the second wave of the waves above the baseline. Above the baseline is a systole, down to baseline is the diastole, and hopefully we taught you in the advanced critical care section in the week of LV and RV assessment how to do this. And the second wave of the waves above the baseline is the S wave, the systolic reflection on the tissue Doppler. And it has to be on the lateral and medial above 10 centimeter per second, indicates that we are dealing with normal systolic function. What we have here is ejection fraction by M mode above 60%, which is totally normal. So based on the left ventricle study that we shared here, what do you think? Is it normal LV systolic with no other concern? Or what you can see is eyeballing, visual assessment, there is a global hypokinesia, mild, or there is normal LV, but I'm concerned about RV. I think I answered this question. It's worthy to you share your thought about this. So what do you choose? Can you go ahead, Habiba, and end the poll here? Let us see. Yeah, so yes, there is a concern. And the concern is that though the RV looks, systolic function of RV looks normal, you can see here the TAP-C. Please notify that TAP-C is M-mode study, and the M-mode line has to be fired to the TAP-C, to the annulus, not to the leaflet of the tricuspid valve. There's difference between when you fire the M-mode on the leaflet. If you look at my fingers here, hopefully you see it. This is the thumb. Let me see it as the leaflet of the tricuspid, and this is the lateral wall, and the annulus is the meeting point between my thumb and my index finger, because I see some colleagues, they fire the M mode on the leaflet. No, this is totally wrong. You have to fire it on the annulus, and as Wissam said, it has to be above. Some people, they say 16, as Abbasi said. Some people, they might say it's above 17 millimeter or 1.7 centimeter. Any number above 16 would be accepted, but any number less than or equal to 16 is considered to be abnormal. Here, the RV function, systolic function, the longitudinal function of the RV is maintained. But if you look at the diameter here, 3, while the LV diameter is only 3.9, so it's above 0.6, so the RV is dilated, but the function is still maintained. You can look and see that there is a tricuspid regurg, as Wissam said, and the pressure across the tricuspid valve here is 40 millimeter mercury, higher than what we can expect for normal. And you can see the notching that Abbasi mentioned before in the RV outflow through the pulmonary valve. So this indicates a high pulmonary vascular resistance. Normal LV function, normal systolic RV function, but the pulmonary pressure is high. What happened later? While the lady was intubated, sedated, she became all of a sudden on the monitor at bedside, heart rate reached 140 per minute, sinus rhythm, blood pressure dropped to 40, 80 over 40. And the ECG, there was no specific ischemic change, but the tropi increased very significantly high. The troponin increased significantly high, and the CK was kept within normal. We repeated the echo. But before we go, what sort of differential diagnosis for this shock is coming to your mind now? Can you please share? Haitham, am I going right with time or?
Yes, on time, doctor. Yes, keep on.
So, Habiba, if you share the poll, what sort of shock is this? Can you expect it as septic shock or cardiogenic or others? I think the clinical case scenario going with a cardiogenic shock due to, I'm expecting, with this marked increase of the troponin due to coronary related pathology. And what I expect to see with echo is regional wall motion abnormality. Can you put the poll, please, Habiba? Yes, 66% expected it to be cardiogenic due to regional motion abnormality. I cannot blame anyone who thought of septic shock because of underlying malignancy, and we can see some rise of the troponin with sepsis. But again, this is the value of point of care ultrasound as a bedside tool, that you can do it, and with a change in the clinical scenario or the deterioration of the clinical condition, you can repeat doing the exam. There is no cost of the 24/7 available machine. There is no cost of radiation. There is no moving patients outside the critical environment or the suite of ICU or emergency. There is no harm of using the point of care ultrasonography. And actually, when we repeated the exam, this is the exam on presentation. Can you tell me if you see anything abnormal compared to what you see here? This is the lateral again, anterolateral, anteroseptal. Here is the inferior, lateral, septal, anterior, lateral, septal, and inferior is here. Look at the views and let us share our thoughts together now answering this question. What you saw is a regional wall motion abnormality of the anterior, lateral, and septal wall, or only inferior, or only lateral. Please, Habiba. Yes, majority said rightly that the anterior, lateral, and septal wall are with significant regional motion abnormality. With this cardiogenic shock, actually, you have to think of that the coronary need an immediate attention, and I have to consult the cardiologist here, and we may push the patient to the angio suite for definitive diagnosis. Look at here again. Lateral wall is barely thickening. How can I identify the regional wall motion abnormality? Look at the wall, only one wall at a time. So you may obstruct the septal wall and look at the lateral wall. And you have to see that the wall during the systole, when the ventricle squeeze, the wall has to thicken to increase in at least 30% increase of the thickness with every systole. and it goes to the baseline with diastole. This is the lateral, this is anterior, and this is inferior. And again, this is posterior or inferior, and this is the septal. And I guess you can see that the walls that we mentioned, lateral, anterolateral, anteroseptal, are all involved. So I would expect that the LAD is involved here. You might have evidence of impaired systolic function. You remembered we said you can measure the TAPC on the right side, you can measure the MAPC, the mitral annulus excursion during the systole, how far this annulus goes up with every longitudinal move of the left ventricle. The more it goes above 1 centimeter, the more it's a normal systolic function. You can do the medial one, again, fire it in the annulus. Lateral and medial, and you take the average of both. Here, the average is around 0.8 centimeter, indicating a bad systolic function. And you can see that the VTI through the left ventricle outlet tract here and the apical 5 can be measured here. It's around 9. The normal is 18 plus minus 3 centimeter. So markedly reduced VTI. The stroke volume can be measured by the area times VTI. So the stroke volume is markedly reduced here. And you can measure the area of the left ventricle outlet tract from the parasternal long, and the machine can calculate everything for you. Here, the machine gives that the cardiac output for this patient is 4.7 liter only. If you have entered the height and weight in your bedside point of care ultrasound machine, then the machine will calculate the cardiac index for you bedside. A test that can take only maybe 1 minute to know. And if you remember, when we did the S-wave measurement with the tissue Doppler of both lateral and medial annulus, we saw it above 10 was normal. Here, look at it. The S-wave, the second wave, is only 7. Is only 7 on the medial, only 7.4 on the lateral. So affected the systolic function. All of this proves that there is a cardiogenic shock here. Good point is that you can also determine if the filling pressure is normal or not by measuring the E to A prime. This is the A prime. Diastole, as we said, in the tissue Doppler is above the 0 line. 0 line is here. Whatever is above is systole. The second wave is S. The wave here is the E prime. So we can use it to determine the left ventricle filling pressure. One of the good messages that I want you to take home from this case is the RV function with LV function. We saw that there was no posterior wall or inferior wall regional motion abnormality. So I'm not expecting the RV to be dysfunctioned with MI because the coronary here is the LAD, not the right coronary. But why the TAPC reduced here? See, the TAPC on presentation was 2.04. Here, when the patient became shocked, it became 1.4. Because as we mentioned several times before, the most common reason for the right ventricle to fail is the left ventricle failure. And the most common reason for the LV to fail is the right ventricular failure, so vice versa. So you expect right ventricle systolic dysfunction with LV systolic dysfunction as well. Thank you very much.
Thank you, Dr. Ashraf, for this great and informative presentation. Until our colleagues write questions for you, we have some questions for Dr. Wissam. Dr. Wissam, some of our candidates asking, in core pulmonary, can we depend on the IVC for the assessment of volume status?
Hi, thank you for this nice question. Actually, when we measure the pulmonary artery pressure, we depend on two things. One of the things called ventricular gradient, and this generated from tricuspid jet. And the other thing
is the right atrial pressure, and this is reflected from the IVC. And we can measure it empirically as the following. For example, if the IVC movement is not rhetoric and normal, we can give the right atrial pressure a pressure between 3 and 5 millimeter mercury. If it is totally plethoric and can't be moved with inspiration and expiration, so we give it empirically pressure between 10 to 15. So if you calculate the sum between this right ventricular gradient, which is normally below 35, and you add the pressure of the atrium, it will give you a systolic pulmonary artery pressure more than 50, which is abnormal. As we mentioned, as the pressure is below 60, we are with pulmonary embolism. If it is more than 60, we encourage core pulmonary. Hope that I answered the question.
Yes, great, Dr. Wissam. Actually, you answered another question, that how to differentiate between the pulmonary embolism versus core pulmonary using the echo. So I think now you answered also this question. There is another question: how can we diagnose acute pulmonary embolism on top of chronic core pulmonary?
That's a very difficult question to answer, actually.
Yes.
Honestly. Yeah, but the scenario here has to be very respected. So if you know that your patient has a chronic core pulmonary, by the way, there is acute and chronic core pulmonary, and anything that comes from the lung and affect the right side of the heart, we call it core pulmonary. The question is acute or chronic. This is very, very important to differentiate. And as Wissam clearly discussed it and nicely explained it, 60-60 sign. The more the pressure across the tricuspid valve is more than 60, and this can be measured, as Wissam said, by Bernoulli equation through the tricuspid jet velocity. The more it's above 60, the more it's unlikely to be acute, it's chronic. And the differentiating point, which is very, very important, is the free wall of the RV. If there is time for the core pulmonale, it's a sense sometimes. So the RV is trying to compensate for the increase of the afterload for a long time. The RV free wall will thicken, will hypertrophy. So any thickness of the RV free wall more than 7 millimeter is considered to be a sign of chronicity. If it's less than 0.7 centimeter or 7 millimeter, this is acute. So in chronic core pulmonale, who developed acute on top of chronic core pulmonale because of pulmonary embolism, in my opinion, it's going to be very difficult to differentiate either by CT or by echo. But the scenario will make the difference. So I have somebody who is COPD, but now coming with chest pain, short of breath, desaturating, the dimer is significantly high.
Right.
I know there is something acute.
Yes.
So this is the only way to differentiate.
Also, we can add that Dr. Abbasi, when he mentioned the DVT, if you find the DVT, you are on the way of pulmonary embolism.
Definitely. You see thrombus, yeah. If you see thrombus, then for those who attended yesterday's webinar, I showed where to see the thrombus actually. The clot in transit, RA, RV, pulmonary artery, or superior vena cava, inferior vena cava, these are the transit. If you see thrombus here with the clinical scenario, then it's a PE. If you see thrombus in the common femoral, as Abbasi said, or popliteal, then when the duct moves as a duct, it's a duct. There is no other proof needed.
And once you have a choice about acute with a nervous outcome, you should do something for this thrombus than to wait as a core pulmonary, which is chronic and can wait for a while. That is like the consequence.
I think we have to move now to, with excuse of my colleagues, we have to move now to Dr. Magid Al-Warraqi to present the next case. We left with, with Haitham. Dr. Haitham Khalifa will present now the fourth clinical case scenario or Pocus scenario, sorry, and we'll end with Dr. Magid Al-Warraqi with a case also of Pocus. And we have to stick to time, Dr. Haitham. I'm sorry if we talk longer, but we need 10 minutes each, please.
Yes. Thank you, Dr. Ashraf. And actually, it is very hard to deliver a presentation after those professional speakers. So my scenario is going to talk about shock. This patient is 62 years old, male. He was feverish, confused, mad, mean arterial blood pressure 55, warm extremity, and lactate. So what type of shock do you expect in this patient from this scenario? He is feverish, MAP is 55, and patient high lactate. So actually, we are expecting most probably septic shock. And as we discussed in our fellowship, different approach for defining the type of shock like Rush protocol and different types. Okay, but now we are going to talk about what about the management of shock. We want to know that not every hypotension equals hypovolemia. This patient echo, you can see the hyperdynamic left ventricle in the short axis, and you can see how IVC is collapsed, and you can see that the lung is dry. So you are talking about the management. Will you give your patient fluid, or you will give your patient medication? So it is very important in our emergency department and in critical care situation to know about the fluid responsiveness. Not all the shock patients are fluid responders. About only 60% of shock patients are fluid responder or preload dependent. So we can measure this fluid responsiveness through different dynamic measurements. One of these dynamic measurements is to check the delta VTI. The VTI is changing during inspiration and expiration. We can measure the VTI velocity time integral through the apical five-chamber view using the pulsed wave Doppler, and then we can check the minimum and the maximum VTI through the equation. If the VTI is more than 20%, and in our patient here is 22, this means that our patient will respond to this fluid. You will increase the preload, and the patient will increase the stroke volume and increase the output and increase blood pressure after that. So there are different dynamic ways to check the fluid responsiveness. So our decision here, according to the Frank-Starling law, our patient here on this part of the curve, when I am increasing the fluid, he is increasing the stroke volume in a limit. After this limit, the patient will not respond to this fluid. Also, if my patient has poor systolic function and I am giving him fluid, he will not use this fluid appropriately. So in this patient, I will decide to start with fluid. I started to give fluid. This is a case of septic shock, and I give from 2 to 3 liters of normal saline. It's a dynamic process. So you are reassessing your patient after giving him fluids. After reassessing our patient, after giving fluids, now the patient, his mean arterial blood pressure not improving, still 60, and the patient now has decreased urine output. So we have to check for the fluid responsiveness for our patient. Now, the delta VTI is 4%. So it means that now our patient is not responding to the fluid, and the IVC started to be dilated or not collapsing with inspiration. So will you decide to continue to give fluid or you will give medication to your patient? In this patient, now he is not responding to fluid, so my decision will to give my patient medication like the NORAD, the vasopressors, to improve his perfusion. After that, we check the creatinine for our patient. Now the creatinine is rising and the patient is still hypotensive. So our patient became congested. So how to assess for the congestion in our patient after giving him fluid? To assess for the congestion, we have what's called the VIXUS score. The VIXUS score is the assessment of the venous excess by the ultrasound. The VIXUS score tell us when to stop giving fluid to our patient. Tell us that the patient is congested and the kidney and other organ may be affected by this congestion. Okay, so how to do this VIXUS component or VIXUS scoring? If the patient started to be congested, the IVC size will be affected and the hepatic veins will be affected and congested because of the increasing the pressure inside the right atrium of the heart. Also, the portal vein will start to be pulsatile because of the congestion, because of the increased pressure in the right atrium. And also the renal vein flow and the renal vein will be affected. So to assess the VIXUS score in our patient, at the beginning, we check for the IVC. If the IVC size is or diameter is more than 2 centimeter, so this patient is suspected to have some sort of venous congestion. So we will go to the hepatic veins. We will put the pulse wave Doppler over the hepatic veins. This is abnormal. This is abnormal wave. Usually the S wave and the D wave is drawn to the down part. But if the S wave is reversed in this patient, if the S wave is reversed, this means that the pressure is increased in the hepatic vein and the flow is reversed from the heart toward the hepatic vein. So the S wave reversed. So this is a sign of congestion. And after that, we go to the portal vein and we put the pulse wave Doppler over the portal vein. Usually, the wave is not pulsatile or pulsatile less than 30 in the portal vein. But now you can see that the portal vein is pulsatile more than 50%. And this pulsatile portal vein reflect the congestion in the severity inside the portal vein. Also, when you go to the renal veins and the renal arteriole and put the pulse wave Doppler, usually the venous flow is continuous. But when the venous flow here is started to be discontinuous flow, it means that the kidney became congested and it will be affected and the creatinine will start to increase. So the VIXUS score in this patient is high grade and it indicates severe congestion. So in this patient, you will decide to stop fluid. You stop the fluid and now you started the vasopressors. After some times, you find that your patient is deteriorating. He became a lung congested, crepitation, desaturating, and lower limb edema. Now you started to reassess your patient again with echo. So you can see that the left ventricular contractility global hypokinesia, now the inferior vena cava is dilated and the lung started to be wet lung. So this patient was a septic shock and now started to be a septic cardiomyopathy, and he started to have some sort of heart failure. So in this patient, you will start to add inotropes to the vasopressor and you will stop fluid in your patient. So usually in the shock, you have to think, will you give fluid or will you give medication? Either vasopressors or either inotropes. You think about the problem and the issue. Is the problem in the preload? So I have to give fluid. If the problem in the contractility, I will use the inotrope. If the problem in the afterload, like in the septic shock, so I need to use the vasopressors. So the fluid responsiveness is a good indication. Sometimes it is better not to give fluid rather than to give fluid to non-indicated patient that may kill the patient. So you have to check for the fluid responsiveness. If you suspected congestion, you have to use the VIXAS score and you have to think about the cause of shock. Either it is preload or contractility issue or afterload. So in our patient, we discussed different scenarios. At the beginning, he was a septic shock, so he was in a preload dependent. And after that, we discussed as a vasodilator shock, as a kind of septic shock. And after that, the patient became congested. So we used the VIXAS score. And at the end, the patient became in a cardiogenic shock, which is a pump failure, and we used the inotrope. Thank you. And if anyone has any question before introducing Dr. Mesht.
Yeah, there's a very quick question here, and please answer it very quickly, if possible, Dr. Haitham. How long from you give the fluid in unstable patients, how long you wait till you see the response in Pocus? Like
Yes.
you measure the IVC or VTI and then you give fluid.
Yes, if I find, for example, my patient in a septic shock or and he is good fluid responder according to VTI variability. So after I finish this fluid, after I finish the 2 liter, after I finish the bolus of 3 liter, I will recheck my patient. And if there is any symptoms appear in my patient, any symptoms in the monitor, I will reassess and check my patient. But if I find that my patient fluid responsive, but the VTI, delta VTI is not high, just in the minimum increase or moderate increase, so I will give fluid cautiously, and after giving this fluid, I will reassess my patient. So it's like a continuous assessment. After giving the fluid or medication, you reassess your patient.
Thank you. Yeah, go ahead and introduce Dr.
Yes, thank you. And now for the last presentation, our colleague and faculty member, Dr. Magid El-Warrai, consultant emergency medicine in UK.
Thank you, Haitham. Thank you, Dr. Ashraf, for the invitation. Okay, Haitham, if you can just stop sharing so I can put my slides on. Okay, so is my slides seen now?
Yeah.
Okay, that's fine. Okay, so I am going to get the final case regarding a patient who already presented with a cardiac arrest, and we will go directly to the case over there. So we have a pre-alert. There is a 26 years old male who already been found by his uncle after 48 hours from last being seen well. He called the ambulance, and the ambulance find him in extreme critical unwellness, and they pre-alerted the hospital. And the initial vitals for the patient: heart rate was 40, blood pressure 70 over 40, temperature was 27 degree, and GCS was 6 out of 15. And shortly after the arrival, the patient went in a cardiac arrest. So before we dig inside the skill, I'm just going to refresh your memories regarding the modules, and also for our colleagues who haven't joined the modules. Okay, so when we are using the Pocus in situation of cardiac arrest, okay, again, regarding the ERC, or European Resuscitation Council, and American Heart Association, okay, still Pocus can be an adjunct with you, can help you regarding the identification of the reversible cause, can also check regarding if there is any cardiac activity over there or not. How we are going to apply this? Okay, so first of all, the CPR is running, and when you are preparing for this, okay, we need someone to be ready with the machine, and you are preparing the defibrillation, and the probe will be on the chest, mainly in subxiphoid area or parasternal, according to the feasibility and according to your layout during the resuscitation. And the probe is already there, and the timer just before the stopping of CPR, he mentioned, okay, 5 seconds for the assessment. And at the same time, when we stop the CPR, at this point, we are checking the rhythm on the monitor. And at the same time, the probe is already on the patient's body and trying to record the clip. At this point, you are not looking for the screen. You are just optimizing, getting a proper image and recording this image. Okay, mainly we need 6 seconds. Following these, stop everything and go back to the CPR, and CPR is resumed again. And while the CPR is going on, we start to analyze the loop of the ultrasound which came out and ask ourselves the focused question: in cardiac arrest, we need to interfere. Which question we are going to ask regarding the reversible cause? If there is any tamponade, we need to intervene as soon as possible. If there is any pulmonary embolism, and we are going to thrombolize, so we can start. And finally, checking if there is any cardiac activity presented over there or not. Beside the diagnostic, also the therapeutic indication for the Pocus, we already discussed earlier in the module. And regarding the prognostication, we can also use that ultrasound to check over there. So at this point, okay, the patient CPR is already going on, and the monitor came out and it showed asystole over there, and the decision to be taken that we are going in the non-shockable rhythm limp in the cardiac arrest algorithm. And at this point, okay, we start to make an analysis to the probe. So we got the image and CPR is resumed, and we got the ultrasound probe. And now we are going to analyze the ultrasound probe. Please be ready. I'm going to, after showing the ultrasound loop, we are going to put a question. So get your mobile phone beside you. You are going to scan a QR code. And after that, we are going to answer the question regarding the ultrasound loop. So CPR is stopped, okay, and we optimize the image. We are recording the image over there, okay, and 6 seconds, stop, okay, and go back to the ultrasound, okay, and this is the loop again. Try to focus on, ask yourself the question, okay, any tamponade over there, any RV dilatation you can evaluate. This is the subxiphoid view. As we can see, the liver is coming over there, and you can see the right side of the heart, the left side of the heart over there. And the check, do you see any cardiac activity happening over there? Any tamponade, any RV dilatation you are able to evaluate. Okay. Going for the poll at the moment. Okay, if you can just scan the QR code quickly and answer the question. What do you see on the ultrasound loop? Is it cardiac standstill? Do you see ventricular activity, or do you see ventricular fibrillation?
You have to teach us, Magid, later on how to use this Menti.com.
Definitely.
It's much better than the other one, the poll that we use.
Okay, so we have 19 responder so far at the moment, 20, and still only 16 get on. And keep it on, because the second question will come shortly after we switch.
we have 123, maybe more than 100. So we need to see your responses. I know we took long time, and but this is very, very important.
Okay, so the majority went right now with the cardiac stent cell. We have 21 responder with a cardiac stent cell and two that there is ventricular activity they can see over there. And one candidate went with ventricular fibrillation. Now two went over there. Okay, so I will get forward, okay, regarding this. And going for the second question, what will you do now? Continue CPR, giving the patient DC shock, rechecking the ECG again, repeating the Pocus. Okay, so most of the responder, okay, they went with a CPR. Four of our candidates already mentioned shock the patient, okay. Despite in the previous question, we already have two or three responding that we have a ventricular fibrillation. Okay, let's pause at the moment, okay, and go again and watch the loop again, okay, and trying to check, okay, if what will be the proper analysis for this. Okay, so this is the loop again. Try to look over there. So CPR is running at the moment. We stopping the CPR, increasing the depth over there. And I want you to try to focus here on the myocardium of the patient. Okay, you can see the flickering over the myocardium over there. And also you can see it on the valves over there. So actually, okay, the patient was in ventricular fibrillation at this time, okay, and it's haven't been picked on the monitor over there, okay, regarding this patient and regarding the clinical context, this can be totally explained, okay, because of the hypothermia, which and especially on a degree of 26, okay, or 27, so we are below 28 degree. So the patient is more liable to go in a ventricular fibrillation. Even they mentioned if you even just touch the patient over there, he can went in a VF. And that's why it's regarding the recommendation of the ALS and even regarding the ECLS in hypothermia, we are go for three DC shock for ventricular fibrillation. And after that, we are not shocking the patient anymore. Okay, because at this point, it will not be feasible for this patient. So the ideal thing which can be done for this patient is doing doing a shock for this patient. But again, here the dilemma is coming. Okay, let me give you the outcome first before we went to the discussion. So the CPR went and no shock is being given at that time for this patient. And we follow the algorithm that the patient is non-shockable rhythm at the moment. So continue CPR, rewarming of the patient, okay, metabolic correction for this patient. And after 2.5 hours, the patient already have lost 10 days later, he left the ITU with a no neurological deficit or organ affection for this patient, just renal impairment, which has already been corrected later on, and the kidney recovered from this. And this was the loop of the patient immediately after ROSC being achieved, okay, for this patient. And you can evaluate here what's the cardiac contractility looks like and when the ventricle is contracting well, and the patient ideally should have an output coming over there. And you need to optimize and differentiate if the patient in pseudo PA or true PAA for this patient. The key physiology, ECG, is mainly the ideal for you if you are checking for the electrical activity inside the patient. Pocus can help you in the mechanical, okay? And in hypothermia, we have a low amplitude regarding the ECG waves, okay? And also regarding the motion itself. So part of the things we need to emphasize on when we are using Pocus in cardiac arrest, if there is no motion, I think there is misbelief at the moment. Still, it's not evidence-based, covered and defended. Okay, if you just see a cardiac standstill, so you stop the resuscitation. Again, we already emphasize, okay, that still there is few cases already recovered after having a cardiac standstill, but you need to start to do your resuscitation using this as a guide for you, an adjunct, okay, to help the decision, but not the only way you are going to go for decision making regarding the stopping of the resuscitation or terminating the resuscitation. Reflection from this case, okay, we need to optimize regarding the ECG itself, considering the fine VF and repeating assessment. And the only tip at this point, you need to assure that if you are using beds or using electrodes, just be sure that they are well connected to the body of the patient, and you can increase the gain, okay, and at this point you may see the fine VF over there. My take-home message, okay, because Pocus can be helping with you, but regarding the rhythm analysis tool, still there is no evidence-based a lot behind. So you need to optimize these. Even you have a suspicion regarding ventricular fibrillation over there, so you can go and check your connection, okay, which will help you over there. Still, there is some case series, okay, mentioning that the already shocked patient been identified as ventricular fibrillation by Pocus, okay, but still we need to follow the guidance, okay, coming from the reputable resuscitation councils, even the American Heart Association or European Resuscitation Council, until the evidence start to come over there and we start to get more dependence and more reliance on Pocus. Standstill not mean futility. Still, some patient can survive. Hypothermia, okay, there is a lot of change you need to be aware of at this time. And again, never stop early. This patient survived not because we were perfect, but because we didn't stop. Thank you.
Thank you very much, Dr. Magid, for this very nice case. And hopefully the messages reached very well. But again, as Dr. Magid shared the knowledge clearly that we should follow the SLS and ALS protocols so far. Thank you again very much for joining this live webinar.
There is one question, sorry, Dr. Ashraf, for Dr.
Go
Majid,
ahead.
if you allow.
It's 1 minute, huh?
Okay, Dr. Majid, just one question. If you find with ultrasound like a Pocus pulsation or Pocus contractility, so they are asking, would you decide, but no peripheral pulsation, would you decide to stop the CPR or continue the CPR?
Okay, at this point, okay, you need to, if I'm already seeing contractility over there, so I'm anticipating that the patient already in profound shock, okay, or ROSC already achieved over there. I'm using the other adjuncts, which is going to help me, okay? We already spoke about the carotid pulsation assessment over there, okay? Because when we already having the evidence behind pulse check using the manual pulse check, okay, it's just show in between the healthcare providers that nearly around 40 or up to 50, okay, are able to detect pulse in patients who already have systolic blood pressure less than 80. Okay, so here we have a lot of fallacies over there, but with more reliance on getting more evidence, this will be like a guide for you that the patient is already maybe in profound shock. There is case series coming from Canada, and I think they have a lot of publication coming shortly regarding the resuscitation, that when they have patient in profound shock, they found ventricular contractility over there, but the patient still not having any pulse. They start to deviate a little bit from the approach, okay, starting to use low doses of vasopressors, okay, and this approach start to show some progress regarding the patient survival after that. But again, we cannot generalize this at the moment. We need to be safe, okay? We need to be following the evidence based until this is coming on. But when you are reviewing the literature regarding the Pocus and the using of the Pocus during the ultrasound, we are progressing over the last 20 years. Okay, so I think within the next 5 years and the next version of the resuscitation ultrasound will have a lot of improvement coming over there.
Thank you very much. I
Thank you,
think
Dr.
we have to
Magid.
conclude
Yeah.
here, Haitham, or not?
Yeah, thank you, Dr. Magid. It's your turn now, Dr. Ashraf. Thank you.
Thank you very much. It was my pleasure to be with all of you tonight. Dr. Haitham Khalifa, Dr. Magid Al-Waraqi, Dr. Wissam Ibrahim, Dr. Muhammad Al-Abbasi, and of course, the great thank goes to ICOM for hosting this webinar, Habiba, Nurhan, and Ala. And also, we should thank WICCEM, Saving Lives Academy, and Sono School. And of course, we thank you all for attending tonight, and see you in the next live webinar next month. See you. Bye.